Good morning, everybody. Today, what we are going to discuss is how you approach a child with heart disease. When a child with heart disease is brought to you, you listen to the symptoms in any medicine or pediatrics patient. Your diagnosis begins by listening to the symptoms of the patient. In this case, the child's symptoms have to be given by the parents. And when the parents give the symptoms, the careful assessment of the symptom gives you the clue to the diagnosis. Therefore, in this session, what we are discussing is the common symptoms of heart disease in children and how do you interpret these symptoms in terms of the physiological significance the symptoms denote. Let's begin with a common symptom, dyspnea. Dyspnea is an unpleasant awareness of one's own breathing. It should be differentiated from tachypnea, where you're counting the respiratory rate and making a statement that it is higher than normal. So what is normal for a child will depend on the age. More than 40 per minute for infants is abnormal. More than 60 per minute for neonates is abnormal. And tachypnea doesn't necessarily mean that it is cardiac, for that matter. Nor does dyspnea mean necessarily that it is cardiac. It may actually mean respiratory origin also. We will look at how these differences come and how we differentiate. In the context of heart disease, dyspnea would denote either pulmonary venous hypertension or something totally different, hypoxia. These are the two reasons by which dyspnea would occur in a child. There are certain terms in relation to dyspnea that you might have already heard. For instance, the word orthopnea means it is dyspnea which occurs immediately after lying down. The person can't lie down. It can happen in older people also. What would happen is that given a person with a compromised cardiac function, the increase in the venous return and the reduction in the diaphragm movement is not tolerated by the patient. That is why a patient in severe cardiac failure is unable to lie down. We use the word paroxysmal nocturnal dyspnea when dyspnea occurs in sleep. In fact, after 2 or 3 hours of sleep, it's a classical feature of left heart failure. It occurs after 2 to 3 hours of sleep. It is relieved in sitting position. Why it would occur a few hours after sleeping while the person is okay while going to sleep? There are a few physiological reasons for that. One of them is relating to the physiological state of sleep in which the patient is. You know that sleep is classified into REM and NREM sleeps. In REM sleep, there is an increased sympathetic activity. So it's like exercise. There's an increase in the heart rate and the blood pressure, which the failing heart doesn't tolerate, and therefore dyspnea occurs. Or in NREM sleep, there is a withdrawal of sympathetic support to the heart. I compare it to turning off a dopamine infusion in a person with heart failure. The failing heart draws upon the sympathetic nervous system for support. So in NREM sleep, as a part of the physiology of sleep, when the sympathetic withdrawal occurs, the heart doesn't tolerate it and the person could go into dyspnea. We said that dyspnea denotes either left heart disease or hypoxia. In the context of left heart disease, what it would mean is there is an increase in the pulmonary venous pressure. The pulmonary venous hypertension, which is the reason for dyspnea, occurs in some settings. When pulmonary venous hypertension is happening, it means the LA pressure is high. The LA pressure is high either due to an obstruction to the mitral valve, or mitral valve is okay, but the end diastolic pressure in the left ventricle is high. So pulmonary venous hypertension can occur due to an elevation of the left ventricular end diastolic pressure, or due to a mitral valve obstruction, or actually due to pulmonary venous obstruction also. In conditions like obstructed TPVC, it is pulmonary venous obstruction which is causing pulmonary edema. So pulmonary venous hypertension due to any of these mechanisms result in a transudation of fluid in the interstitium. As a result, there is an increase in the respiratory effort which is needed to move the congested lung. Remember, there are J receptors in the interstitium, and they get stimulated when there is fluid in the interstitium, and this J receptor stimulation brings respiratory center stimulation, and hence the tachypnea component of dyspnea sets in. And when the baby or the older child is doing an increased respiratory effort without proportionate lung expansion, there is intercostal and subcostal retraction. Inspiratory effort is more, but there is no proportionate expansion of the lung. This is the reason why intercostal and subcostal retraction occurs in pulmonary edema. So left heart disease, it is pulmonary venous hypertension due to obstruction at the level of the mitral valve or pulmonary veins, or elevation of the LV end diastolic pressure due to left ventricular failure, which causes pulmonary venous hypertension, transudation of fluid into the interstitium, J receptor stimulation, greater respiratory effort to move the lung, and hence dyspnea. Totally different mechanism is at work in the case of cyanotic congenital heart disease. In cyanotic congenital heart disease, you have hypoxia. Let's say pathology of fallow as the example. You have hypoxia, and as a result, there is a stimulation of the respiratory center, and hypoxia brings in acidosis. This also stimulates the respiratory center, and as a result, there is a tachypnea. So when a pathology of fallow, which is a prototype of a cyanotic heart disease that you can think of, is patient is exercising, what happens is, with exercise, there's an increase in the venous return and an increase in the right to left shunt, drop in the PO2, arterial PO2, stimulation of the respiratory center, and hence tachypnea. Continuing exercise is anaerobic, and therefore there is acidosis which is happening, and the drop in pH also results in a respiratory center stimulation. So you have two different mechanisms for left heart disease and hypoxia to initiate pulmonary venous hypertension or respiratory center stimulation due to hypoxia as the mechanism for dyspnea. It is useful to assess the clinical status of the patient to grade dyspnea. The older child or adult can be graded based on New York Heart Association. In New York Heart Association, class 1 is diagnosed heart disease and no symptoms. So there is no dyspnea. Let's say a patient with mitral stenosis does not have dyspnea, any symptom. It's mild mitral stenosis. You say it is mitral stenosis, functional class 1. Class 2 is dyspnea with ordinary activity, like maybe walking a kilometer, walking a few hundred meters. That is class 2 dyspnea. Class 3 is less than ordinary activity provoking dyspnea. This happens when, let's say, a person is walking in the room or walking from one room to another and there is dyspnea. You would say the patient is in class 3. Class 4 is inability to perform any activity without dyspnea. What this means, if the person puts one step out, he becomes dyspneic. That is class 4. If he is orthopneic, of course he is in class 4. So that is how you will classify NYHA as class 1 to 4. And obviously this shows an advancing functional class, a deteriorating functional class, helps in recognizing the severity of the patient's disease. There's a problem for children in trying to apply the NYHA class because the baby doesn't walk the way you would like the baby to walk. This is why the Canadian Pediatric Society has introduced the ROSE classification, in which class 1 is asymptomatic. So if a child has atrial septal defect and the child has no symptom, we can say the child is in ROSE class 1. But if a child with VSD has mild tachypnea or mild sweating with feeding, then you say it is class 2. In an older child, this would be a dyspnea on exertion, similar to NYHA class 2. In class 3 in an infant, the problems are provoked by feeding, but there is profound tachypnea and sweating. And an older child, marked dyspnea on exertion, similar to class 3. In an infant, class 3 ROSE is associated with a prolonged feeding time and growth failure. And class 4 is a terribly sick baby with retraction, grunting, and diaphoresis, equivalent of, say, pulmonary edema in the older child. So this is how ROSE classification is used to grade the child or infant with heart disease. We have explained the dyspnea in hypoxia. This slide illustrates it further. The exercise is increasing the heart rate and increasing the venous return. Consequently, there is a desaturation, and the drop in PO2 is stimulating the respiratory center and causing dyspnea. Systemic vasodilatation is in the case of tetralogy, the systemic vasodilatation encourages the right ventricle to pump into the aorta, causing a greater right to left shunt. Dyspnea in infants manifests as a feeding difficulty. What is the difficulty is when the baby is trying to suck on the nipple, the baby becomes dyspneic and tired, and he or she has to leave feeding. So the baby sucks at nipple, becomes dyspneic, stops after a small feed. During this interruption, you find dyspnea, you find the baby to be dyspneic, tired, and sweating in the forehead. The baby rests for a few minutes and then starts sucking again. So this is called the suck, rest, suck cycle, simply referred to as feeding difficulty or as suck, rest, suck cycle. The mechanism of pulmonary venous hypertension that we explained is operational here. It is only that instead of, or rather the exercise that provokes the pulmonary venous hypertension is sucking. In the older child or infant, congestive heart failure would manifest as respiratory distress, sweating, cardiomegaly, hepatomegaly, and often a low blood pressure. In children, the timing of presentation tells you about the clue to the diagnosis. For instance, the reasons in a neonate are different from a reasons in a 10-year-old child. I will not go into that in this discussion. But move to another major symptom, which is failure to thrive. Failure to thrive is a term that we would apply to children below 5 years. In a child whom we say is failing to thrive, the weight is below the third percentile, and there is if you look at the weight for height C-score, it is less than 2 standard deviation for age. The pathophysiology is that in congestive heart failure, there is a feeding difficulty and decreased caloric intake. There is an increase in catabolism. There is a recurrent respiratory infection. Systemic venous congestion may cause portal venous congestion, anorexia, decreased absorption from the gastrointestinal tract. And the failure to thrive may be part of syndrome, example, DiGeorge syndrome or rubella syndrome, or recurrent infection may be due to a low immunity. So this is how failure to thrive gets linked to heart disease. And recurrent respiratory infection, which is a common manifestation of congestive heart failure in children, you use the term when there are more than 4 to 6 episodes of lower respiratory infection in a year, or at least 2 episodes requiring hospitalization or IV antibiotics. It's commonly seen in post-tricuspid shunts because there is a left ventricular failure and pulmonary venous congestion. It's not a feature of an atrial septal defect. What happens here is the interstitial edema and pulmonary venodilatation cause compression of the bronchioles and retention of secretions. And due to pulmonary venous congestion, anastomotic channels between pulmonary veins and the bronchial veins open up, leading to bronchial mucosal congestion. Bronchial mucosal congestion and goblet cell hypertrophy leads to impaired mucociliary clearance. And dilated left pulmonary artery, which happens in large left to right shunts, may cause compression of the left bronchus, resulting in retention of secretions and impaired clearance. And poor immunity associated with poor weight gain will predispose to recurrent infection. From failure to thrive and dyspnea, we move to another symptom, which is exertional fatigue. This means there is no enough skeletal muscle perfusion during exercise. Therefore, the person feels very tired in the muscles after walking a short distance. This signifies a low cardiac output. If the cardiac output is fixed and the person is unable to increase the output during exercise, this is what would happen. And cardiac output is fixed. On the right side, if there is severe pulmonary hypertension or severe pulmonary stenosis, particularly with the right heart failure, and on the left side, if there is severe aortic stenosis or hypertrophic obstructive cardiomyopathy, these are reasons for fixed cardiac output. So they're living on the edge, and when they exercise, they can't increase the output further to supply the exercising muscles. So this is recognized as fatigue. And something more sinister can also happen, which is syncope. Syncope is a transient loss of consciousness due to decreased cerebral perfusion. Syncope may be exertional or rest. It is exertional syncope that happens in children with a fixed cardiac output, either on the left side or on the right side, as we just discussed. It is believed that there is a stimulation of mechanoreceptors in the LV myocardium, triggering a Basol-Jarisch reflex as a mechanism for this. The Basol-Jarisch reflex is a vagal stimulation reflex. So these mechanoreceptors in the LV during exercise, as the LV is contracting more vigorously, the more the mechanoreceptors are stimulated, and they cause a vagal stimulation causing bradycardia, vasodilatation, drop in blood pressure, and syncope. An exercise-induced arrhythmia may also be a reason for exertional syncope. The reasons for this we have already discussed. When syncope occurs at rest, that's a different matter. In fact, the commonest form of syncope does occur at rest, which is a vasovagal or neurally mediated syncope. All of us have had a syncope or more when we have been standing for a long time, typically in an assembly, in a prayer meeting, or you have been in a line for a long time. These are the times when your vagal system is more active, that there is a peripheral pooling of blood, and you're unable to maintain your upright position transiently. And the moment you hit the ground, you become all right. That is vasovagal syncope. Positional syncope, in some position syncope is brought, is due to a LA myxoma plopping in and out of the mitral valve. The Stokes-Adams attack in complete heart block. In complete heart block, when actually the complete heart block occurs, there's a profound bradycardia or asystole, and during this time the patient gets a syncope. It recovers when the rate improves. If it doesn't improve, the patient will not survive. You can also have syncope related to certain specific modes of activity, like swimming, syncope on running. After running, the person drops down with a syncope. Or there's a syncope on hearing a loud sound. These are manifestations of long QT syndrome. Long QT syndrome is a congenital channelopathy where there is a long QT denoting a prolonged repolarization of the ventricular muscle, which will trigger some lethal arrhythmias. And one of the manifestations is syncope occurring under these settings. Palpitation is a much more common symptom, and all of us have had palpitation at one time or other. But when the awareness is unpleasant, that is when we actually call it a palpitation. There is an unpleasant awareness of one's own heartbeat. It can be exertional, it can occur at rest, or it can be paroxysmal. Exertional palpitation means there is a volume loading of the heart. Maybe the right heart, like an atrial septal defect, or the left heart, like a mitral regurgitation or a PDA. When the heart is volume overloaded, there is a cardiomegaly. When the person exercises, the heart rate increases, and the more forceful contraction is perceived by the patient as palpitation. An arrhythmia can also result in a palpitation at rest. The typical manifestation of arrhythmia is as a paroxysmal palpitation. Before I explain what's a paroxysmal palpitation, the non-paroxysmal palpitation is a sinus tachycardia. See, all of us, when we get excited, when we are walking fast or running, jumping upstairs, our heart rate increases, and this is due to a sinus tachycardia. The increase is gradual, and there will be a gradual decrease once your exercise is over. Or when you're facing, let's say, an examiner for your viva, if you're excited, you have a palpitation as you're seeing the examiner. But as the examiner puts you at ease, your heartbeat starts decreasing and you're able to answer the questions. And once you come out, in a few seconds' time, your heart rate is okay. This is normal. But in paroxysmal palpitation, there is an abrupt onset and an abrupt termination of the tachycardia. The maximal heart rate is achieved in a single beat's time. One beat ago, the heart rate was maybe 70 or 80 per minute. And one beat raises it to 200 per minute or 300 per minute. And you have an uncountably fast rate. That is paroxysmal palpitation. And parents, in small baby's case, may note neck pulsations, or if they are keeping their hand on the baby's chest, they may appreciate the increase in the cardiac activity. The older children may complain of polyuria during the palpitation, and they may also say that an unintended vagotonic maneuver, like straining or straining a stool or stimulating the throat, may terminate the palpitation, because the vagal stimulation tends to stop a supraventricular tachycardia. Chest pain, I have deliberately kept much later in the discussion. If there is one thing about chest pain that I want to tell you, is that chest pain in children is very unlikely to be cardiac. I would repeat it, a chest pain in a child is extremely unlikely to be of cardiac origin. Cardiac chest pain, if it occurs in children, may be due to pericarditis, very, very rarely due to a coronary abnormality. Congenitally, the left coronary artery may arise from the pulmonary artery. This may cause ischemia to the left ventricle. And in an infant, distress and irritability during straining may be the equivalent of an angina in an older patient. The coronaries may be normal in origin, but they may pass between the two great vessels, what we would call interarterial coronaries. They can also get compressed during exercise and cause ischemia and could be a cause for sudden death. Coronary artery disease in children can occur in Kawasaki's disease or Takayasu's disease. These are uncommon causes of ischemia and uncommon causes for chest pain. The commonest chest pain in a child is muscular in origin. A hypertrophied right ventricle or left ventricle, as in Eisenmenger syndrome or LVOT obstruction, severe RVH or severe LVH, the hypertrophy outstrips the capillary density. As a result, there is ischemia. This can also be a reason for chest pain. Edema and facial puffiness in a child, in an infant usually, it denotes systemic venous hypertension. And the cause is congestive heart failure or severe tricuspid regurgitation in a postoperative child, like tetralogy repair, where there's a severe RV dysfunction. It can be a cause for facial puffiness. Severe pulmonary arterial hypertension can also be a reason for RV dysfunction. A major symptom and sign is cyanosis. Cyanosis is a bluish discoloration of skin and mucous membranes due to increased concentration of reduced hemoglobin. The amount of reduced hemoglobin that you need in the arterial blood gas to cause visible cyanosis is more than 3 grams per cent. More than 5 grams per cent in the capillary blood will cause cyanosis to be apparent. The reason for cyanosis need not necessarily be cardiac. If you're not breathing, you're going to be cyanosed. So neurological or musculoskeletal reasons that interfere with respiration will cause cyanosis. Of course, there is cardiac cyanosis. And cyanosis, the other way to look at it, it may be central or peripheral. When there are cold extremities with cyanosis, you call it peripheral cyanosis. It disappears on warm. When in a newborn or a young infant, there is doubt about a cardiac versus respiratory origin of cyanosis, one useful, simple tool is that a peaceful cyanosis is cardiac. Respiratory distress means a lung disease. Look at a baby with TGA. Baby has a saturation of 60%, but the baby looks all right, even though the respiratory rate is a little fast. Quite unlike a baby with pneumonia, if it's having a saturation of 60%, it will be requiring ventilation. It will be in that much of respiratory distress. When you see a cyanotic baby, whenever you have doubt as to whether there is a baby, whether there is cyanosis or not, you check the SpO2 for confirmation. In any case, checking SpO2 is a part of today's physical examination in a child. And where there's doubt about central versus peripheral cyanosis, keeping the baby warm will answer the question. And when there is doubt as to whether the cyanosis is cardiac versus respiratory, the presence of respiratory distress and response to oxygen will help. If cyanosis is due to a respiratory pathology, giving 100% oxygen for 10 minutes would improve PO2 to above 300. If it stays below 150, there is mixing at the level of the heart and the cyanosis is cardiac. In a cyanotic baby, if you were to do an arterial blood gas, pH will be low, let's say 7.25. PO2 will be low, let's say 35. And PCO2 will be low, let's say 20, all in millimeters of mercury. And chest X-ray will show the heart size and configuration like the boot-shaped harp of tetralogy and the reduced lung vascularity of tetralogy. This could be diagnostic in a given setting. The ECG will also be helpful by showing the axis and which ventricle is dominant. This is just to tell you that cyanotic congenital heart disease is classified as having a reduced pulmonary blood flow or increased pulmonary blood flow. Tetralogy of Fallot is the prototype of conditions associated with reduced pulmonary blood flow. There are other conditions which will go along with it. The low PO2, oligemic lungs, and response to prostaglandin are features of reduced pulmonary flow situation in the newborn. The increased pulmonary blood flow situation, the best prototype is TGA, TPVC, single ventricle, truncus, all are causes for cyanotic congenital heart disease with increased pulmonary blood flow. And they all have cyanosis, heart failure, cardiomegaly, and in general, murmurs are unimpressive. A cyanotic spell is a very grave symptom. It's a rapid decrease in systemic oxygen saturation with hyperventilation. And if unchecked, it will progress to convulsions, coma, and death. The age is 6 months to 2 years. Please remember that cyanosis on crying is not a spell. Any cyanotic child will have worsening of cyanosis on crying. But the association with hyperventilation is the defining feature. Crying or exercise may trigger spells. What would happen in a tetralogy when a spell occurs is that there is a drop in systemic vascular resistance or infundibular spasm triggered by activity or crying, which causes a worsening right to left shunt, acidosis, stimulation of the respiratory center, hyperventilation, inability of the chest wall muscles to contribute. The chest wall muscles are active, but the lungs are unable to increase the blood flow to it. So there is a vicious cycle. And this is the reason why cyanotic spell becomes a very grave problem. If you see this cartoon, if this, look, here with the blue blood is the right heart. This is the VSD. This is the overriding aorta. This is the smallish pulmonary artery with an infundibular obstruction. But there is a good antegrade flow here. Look at this image. The two sides of the infundibulum, the muscular obstruction, they are kissing each other. There's hardly any antegrade flow. There is more flow into the aorta. That is what happens during a spell. Closely linked in mechanism is squatting. In tetralogy of Fallot, when a child tells you that he gets dyspnea on exercise and the dyspnea is relieved on squatting, it's a very typical symptom. There are many squatting equivalents also, sitting with legs drawn underneath, legs crossed while standing, the mother holding the baby with knees drawn towards chest. All these are squatting equivalents. When the baby with severe cyanosis squats, the kinked femoral arteries would increase systemic vascular resistance. The kinked femoral veins will lock up desaturated blood in the lower limbs, and the better saturated mesenteric venous blood is displaced into the lung, into the heart. All these help in improving the saturation. We speak of a differential cyanosis in Eisenmenger PDA because the pulmonary artery is supplying the lower limbs through the ductus. You speak of a reversed differential cyanosis in a TGA with coarctation and PDA. And sometimes the baby looks otherwise okay, but is cyanosed. That is a feature of pulmonary AV fistula or a systemic venous anomaly, like an IVC draining to the left atrium. So these are some of the symptoms that we discussed. Thank you very much.